Hi everyone, this is Neil Writer, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have here a patient who has to attend biannually to have their ears cleaned of this dead skin, dead keratin buildup that they experience very deep in the ear. So all this skin that I'm removing was once a layer on their eardrum, and that layer of skin had died and shedded and was replaced by another layer of skin. And that skin should then naturally migrate out of the ear. The ear has evolved to shed itself and cleanse itself of any dead skin that it accumulates in the ear. If it wasn't able to do that, in this particular case, all of our ears would be blocked full of dead skin. And I'll be very, very busy removing a lot of people's dead skin from the ear. So our ears have evolved to do that, and it all starts from the eardrum. So the eardrum, the outermost layer, is made up of the same skin that lines the inner two-thirds of the ear canal. It's the epidermis, the outer layer of skin, and it consists of epithelial skin cells. And as that skin dies, it's replaced by another layer of skin, and that dead skin is then pushed away, and that skin should then migrate sideways from the eardrum, slowly but surely, across the ear canal and eventually out of the ear. And that rate of migration, we call it the epithelial migration, it varies from individual to individual, but it's around 1.5 millimeters to 3 millimeters a month, and you can compare it to the growth of our fingernails. So I've just performed microsuction. I removed that from the patient's ear. There's just some dead skin around the tertium I'm going to just peel away. You may have noticed on the patient's eardrum, just adjacent to the hammer bone, so anteriorly, there's a little tympanosclerotic patch there, so it's a bit of scar tissue, calcium deposits, and that's gathered into the middle fibrous layer of the patient's eardrum. So they have previously undergone some trauma in this ear. Now, if you stay tuned, the writer is actually a bit more of an interesting case, and that's because the patient underwent a tympanoplasty. They suffered from a perforation of the eardrum a few years ago, and that was due to otitis media with effusion, also known as glue ear. They had infected fluid behind the ear that had gathered, and it wasn't able to drain out of the eustachian tube, which is a narrow tube that connects the middle ear to the back of the nose, and that caused the middle ear to fill up with fluid, and eventually that fluid had to go somewhere, and as a result it punctured through the eardrum, it burst through the eardrum, so the patient was experiencing weeping discharge out of the ear, and it left him with a hole in the eardrum which didn't heal. Sometimes tympanic perforations can spontaneously heal. It can take between 6 and 12 weeks, but this patient's tympanic membrane failed to heal and just suffered from continuous chronic infection. So the ENT surgeon decided to perform surgery, and they performed a tympanoplasty. They fitted a cartilage graft to seal the hole. Now, similarly to their left ear, the skin on the eardrum has failed to migrate, and it's hard to see at the moment. It's not as obvious as the patient's left ear, but you will see me begin in a moment to peel away dead skin off the eardrum. At present, I'm just peeling away all this peripheral dead keratin around the edge. So this skin again was once on the eardrum, and it's able to migrate somewhat out of the ear, but it's still within the inner last third of the ear canal, and it's halted there. It's failed to migrate any further. So I'm just using the fine end suction probe here, and just delicately trying to peel this off on the base of the ear canal. We've got to be careful because we are working on the bony part of the ear canal. This region of the ear in particular is very sensitive. The outer third of the ear canal, the cartilaginous portion, that's has got a thicker layer of skin. It's about 1 millimeter in thickness, and that provides a buffer, and it's got the innermost layer of that skin is made up of insulating fat and connective tissue, whereas the skin that lines the inner two-thirds of the ear canal, the bony part, the osseous region, is less than 0.1 millimeters in thickness, and there's no insulating fat. It's just the outer layer of skin, the epidermis layer. So now I'm beginning to peel away the skin off the eardrum, and it was a bit deceptive. I wasn't sure if there was a layer of skin because the patient's had surgery. There is the eardrum itself is a bit dull in appearance and a bit scarred, but you can tell at the top of the eardrum that skin has begun to crust and oxidize. So I kind of knew it was a layer of skin because of that. It gave it away. And it is very difficult to remove. And I remember the patients already had previous surgery, so we're going to be really gentle and careful here. And slowly but surely, I'm just peeling the skin away. The last thing you want to do is perforate this patient's eardrum again, and we're going to have to undergo further surgery. And the cartilage graft is posteriorly, so where I'm beginning to peel away the skin, it's just positioned to the back part of the eardrum. And you'll see that eardrum it just looks a bit thicker. You can just see the short process of the hammer bone just peering through the cartilage graft. There's a piece of bone there at about 12 o'clock. So that's the hammer bone, that's the top part of the hammer bone, also known as a short process. So that's just revealing itself. In a normal, healthy-looking ear, you'll see the whole manubrum, which is the handle of the hammer bone, the main section that you see running vertically from 12 o'clock to the middle, to the bullseye region. But because of the surgery, it's not as